summary panel where you'll get to ask presentations, and the interactive Q&A will give you a chance to dive deeper into these subjects. How do we maximize structure and function? And how do we determine progression through analysis in our glaucoma patients? I'm Jack Chaffee from Columbia University, and on behalf of the panelists, who I'll introduce in a second, I'd like to welcome you to the symposium. Our first presentation today will be given by Dr. Sarah Van Tassel from Weill Cornell Medicine in New York. Our second presentation will be given by Professor Shunpei Ogawa from Jikei University in Japan. Our third presentation will be given by Dr. Marta Paso from Barcelona, Spain. The first presentation today by Dr. Van Tassel is on OCT and the macula within glaucoma management. Dr. Van Tassel.
Thanks for the introduction. I'll be speaking on the topic of OCT and the macula within glaucoma management. I received support from Zeiss, who's supporting today's talk. So why are we discussing the macula? In glaucoma, both the ganglion cell soma and the associated axonal fibers are damaged. And while the retinal nerve fiber layer atrophy gives the characteristic appearance of the optic nerve that we're used to seeing and thus receives a lot of attention, the ganglion cells are also very important. And we can look at the ganglion cells or the volume occupied by the ganglion cells in OCT. First, a few words on examining the printout. If you're accustomed to doing OCTs with just the RNFL, then you know about signal strength. But the signal strength also appears at the top of each printout for the ganglion cell analysis. This ranges from 0 to 10, and the recommended threshold for high quality scans is greater than or equal to 6. After I've looked at the quality, I search each scan for artifact. There are myriad causes of artifact, and they're frequent in scans obtained for glaucoma. As many as about a third of scans may have artifact. Here's an example from my clinic of 2 baseline scans, and then in the third scan, it gives perhaps the impression that there's inferior RNFL thinning. But as you can see here, there's actually a Weiss ring that's causing this shadow of the circumpapillary scan, and that gives this artifact up here. So you can't really know if the patient is thinning inferiorly or not. Next, I look at the material on the scan that I actually want to use to interpret. So I like to use the RNFL thickness and deviation maps delineated here in black, as well as the ganglion cell thickness and deviation maps. So here's a few patient examples. Here's a patient who came to me, they're a myope, they have this inferior RNFL thinning that you can see in the RNFL thickness map and in the deviation map. And of course, this draws your attention and it's suspicious for glaucoma. But you can see that the ganglion cell analysis really helps to make the diagnosis for you. This patient clearly has glaucoma in both eyes, as shown by these inferior areas of thinning in the ganglion cell analysis. And I want to highlight 2 particular things. One is that over here you see that all the quadrants are green, and so you really have to remain attentive to not letting the color of the printout overly influence your interpretation. The other thing I want to highlight here is how wonderful the PanoMap can be to stitch together the RNFL scan and the GCL scan or the macula to really illustrate what's happening. Here you can see the Cirrus machine stitches these images together, so you see this arc of diseased glaucomatous tissue inferiorly, and you can really appreciate the relationship between the macula and the RNFL. Here's an example of reassuring ganglion cell analysis. This is a patient, again, somewhat suspicious for glaucoma. You see these areas of RNFL thinning that perhaps draw your attention. Also, your attention is drawn to this PVD artifact here. But you can see that the ganglion cell scan really shows you that the macula looks pristine in this patient. So certainly they're at risk for glaucoma in the future because of their cupping, but you can really exhale when you see this scan and not worry as much about glaucoma in this patient. Another example here of a patient who was referred for glaucoma suspect due to cupping. And while you can see that there's some RNFL thinning here, your attention should be drawn to the fact that this is somewhat atypical appearing in shape. And in fact, again, the ganglion cell analysis really makes the diagnosis. You see this retrograde transsynaptic degeneration in the macula. And in fact, this patient had a large right MCA stroke. So of course, their visual field also shows a homonymous defect. But you can see here that the macula, and in particular the panomap, really help to connect the macula and the RFL and show you what's happening with this patient. We can also use the structure to guide our impression of function. Here's a patient who is new to me in the office, a pretty good visual field taker for a new patient. And you can see here that the visual field has these superior test points that were abnormal on the pattern deviation. The glaucoma hemifield test was outside normal limits. But defects like this can be easy to disregard. You might attribute it to lid, or you might write that it's non-specific. But we can use the OCT to help guide our impression of the visual field. In this patient, your attention is drawn to this area of inferior RNFL thinning, but it's really the macular scan that helps to make the diagnosis here. You see this arc of diseased tissue, and now you know that this visual field defect is in fact probably real. And this matters because a defect at diagnosis helps to prognosticate. Eyes with a field defect at diagnosis are more likely to progress to blindness than eyes treated when they have a structural defect but no field defect. So this motivates more aggressive treatment. It motivates a lower target IOP than someone with a similar OCT and a normal visual field. Next, I want to transition to two examples of how we use OCT in patients who have the more central 10-2 type of visual field defects. Here's a patient who had been followed for years for a floater by their comprehensive ophthalmologist, and it wasn't until they developed this disc hemorrhage that they were sent for glaucoma evaluation. Here you can see on the visual field test, they missed these paracentral pixels in the center. And on the 10-2, that's well characterized as a paracentral superior arcuate defect, probably what they were calling their floater. And you can see here that the macular scan really highlights this fixation-threatening defect. If you looked only at the circumpapillary scan, you would just see this inferior and temporal RNFL thinning, but you can really see that the ganglion cell atrophy approaches the fovea. Here's a separate example in a different patient. Of course, your attention is immediately drawn to the inferior arcuate defect, but they also have these superior paracentral pixels. This is well characterized on their 10-2 scan. And again, you can see that there's great structure function correlation. And you can see in particular this parafoveal area of macular loss, of GCL loss. So in conclusion, interrogate your scans for artifact. Use the RNFL, the optic nerve, and macular criteria for evaluation of OCTs. These are complementary. And remember that OCT is an important quantitative aspect of structure in glaucoma assessment, but it's not a replacement for nerve examination or for perimetry. Thank you.
Thank you, Sarah. We look forward to discussing this at the end during the Q&A session. Next, we'll hear from Professor Ogawa discussing HFA during case presentations.
I would like to thank all people who gave me this opportunity. This is Shunpei Ogawa from GK University in Tokyo, Japan. I'm going to talk about functional testing. I have no COI to declare. Recently, HFS3 installed new two programs, which are 24-2C and Theta Faster. I would like to talk about this 24-2C Theta Faster CSFR today. This is background of development of the new programs. The first threshold was developed in 1984, and then Theta was in 1997. Since Theta development, about 2 decades, we have used this program as gold standard for glaucoma management. On the other hand, progress of OCT in these 2 decades was remarkable, as we know. Time domain OCT, spectral domain OCT, and OCTA were developed. And those OCT technology has changed the practice of glaucoma. One example is the pre-perimetric glaucoma, PPG. OCT progress made a new glaucoma stage. In such a situation, the two programs came out. We have used mainly 30-2 or 24-2 program and appropriately added 10-2 as an evaluation of central visual field. For example, in advanced stage, 30-2 just provide rough information of the central visual field. When we look at 10-2, we can see the temporal lower and upper visual field are still preserved. In early stage or preperimetric glaucoma, (PPG), 30-2 misses this central visual field defect. 10-2 detected. So testing 10-2 is important to understand central visual field condition. The 24-2C program is combining 24-2 and 10-2 test points. Considering the path of retinal nerve fibers in the macula, selected 10 test points from 10-2 were added to the 24-2 test points. These additional test points vertically and asymmetrically cover vulnerable zone of the macula. I will show a case of NTG. In this fundus photograph of left eye, you can see the RNFLD at the temporal lower. So, 3 types of visual field tests were conducted. 24-2 theta standard SS detected nasal upper visual field defect corresponding to the RNFLD. 10-2 SS also detected central upper visual field defect. But 24-2 CSFR could detect both central and peripheral VFD well. In addition to that, test time of CSFR was shortest. It was 2 minutes and 47 seconds. This is our data. We examined 125 eyes of 125 subjects, including glaucoma, glaucoma suspect, and normal subject, using both 24-2 theta standard and CSFR. These plots show a relationship between mean deviation and test time. Blue dots are SS and red dots are CSFR. In both groups, as MD worsened, test time tended to be longer. With CSFR could shorten the test time efficiently regardless of the MD value. A sub-analysis was conducted only for patients aged 75 years or older. As shown in this figure, CSFR also shortened the test time for the elderly patients. Then we compared those 14 test points between CSFR and 10-2 SS. Subjects were 55 glaucoma eyes. Other informations here. We counted a number of simple plots of total deviation and pattern deviation in each hemisphere. Only the number of less than 2% symbol of TD in the lower hemisphere was significantly different between the two programs. The others had no difference. These results indicate good agreement between CSFR and 2-2 SS. Then we compared retinal sensitivities in each test point between two programs. In the right figure, blue means additional 10 and identical 4 points. These 3 red points were significantly different between two programs. 10-2 SS had higher sensitivity in the 3 test points. The others had no difference. Interestingly, these three test points are most central test point of 24-2 are not additional test points. It is considered that the retinal sensitivity of these three test points of 10-2 SS were significantly higher due to the influence of inner adjacent points that maintained good sensitivity. The correlation coefficient of two yellow test points were less than 0.6. It seems to be low correlation. So care must be taken in interpreting of these test points results. So far, we've seen the good side of CSFL, but there is a case like this. This is a 56 years old female. In fundus photograph, we can see the RNFLT pointed by yellow arrows. By optic nerve head analysis, RNFLT was unclear. But in macular analysis, there was obvious GCIPL defect in the lower hemisphere, which is corresponding to the RNFLT. These are the results of three types of visual field test of the patients. 30-2SS detected 1-point visual field defect in PD with less than 0.5% plots. 10-2SS also found more precise visual field defect in upper side, but CSFL could not provide additional information more than 30-2SS. So in such a PPG case, even if CSFL is almost normal, we need to measure 10-2 to confirm structural change. Here is a summary of this talk. Thank you for your attention.
Thank you, Professor Ogawa. Last, we'll hear from Dr. Pazzo and a discussion of progression and what role the macula plays in determining progression and how we use it in glaucoma management. Dr. Pazzo.
Right. Hello, everyone. Thank you very much for the invitation to be here today. And I'm going to talk about progression and what role does the macula play in glaucoma management regarding the change over time of the disease. So for the purpose of the presentation, I'm going to divide it in 3 blocks. First is going to be structure, then function, and then finally, I'll talk about OCTA. In structure, it's very important to first differentiate progression from variability of the instrument. So GCIPL has shown an excellent intratest reproducibility with ICCs of almost 1. And from what we know from studies published is that we need to have at least 4 microns of change to suggest true change in the macula in glaucoma. The other thing that we have to take in mind is aging, because there is a significant loss of retinal ganglion cells with aging, and just as it happens with retinal nerve fiber layer thickness, GCIPL thickness also decreases over time. Actually, there's a physiological rate of about minus 0.32 microns per year. We have to take this into account when we see the slopes, because if we consider a statistically significant slope as a significant change, we may have high false positive. We always need to have in mind that the change has to exceed normal aging for our particular patient. Then, in what cases macular structural change can help us in clinics? First, in advanced glaucoma, because GCIPL has a less floor effect compared to retinal nerve fiber layer. Therefore, there's still room for change in the macula in these advanced cases to still see structural progression. Second, in cases of high myopia, it has been shown that monitoring macular GCIPL thickness is still effective to predict progression in these patients. And there are also a lot of reports saying that early loss in glaucoma can also be detected in the macula, and actually it's complementary information to that obtained with P retinal nerve fiber layer. I'm showing you a case. This is a 75-year-old male that has, as you can see in the field, an advanced glaucoma. He has already had a TRAP in the past. IAP is 18. You can see here that there's no change in the visual field over time, and that the retinal nerve fiber layer has reached the floor effect. However, the macula, here we can see that there's significant change. It's almost losing 1 micron per year. And when we looked at the events graph, we can see that there's significant central change. So our patient is progressing structurally. We'll go now to talk about a little bit of function. So there are functional tests that can explore the macula, and we will use them to assess progression as well, because visual field testing is still the gold standard to evaluate progression in glaucoma. We have always used central strategies to evaluate progression in advanced glaucoma. However, recently, we are using more and more visual field to study early glaucoma and to have better information of the central damage that occurs in the macular vulnerability zone. However, there's not clear evidence to include 10-2 in all patients routinely. And 24-2C, which has some central points, has been shown to be useful for screening. However, is also not clear if it's needed to be used in all our patients. I'm showing you here another case. This is a 57-year-old female that has a normal tension glaucoma with a very focal temporal inferior notch. We can see here in the first test that there's almost no visual field damage. However, in the following test, because we saw that focal inferior notching, we decided to do a 24-2C in order to have more information. And we found out that there was those important significant changes very close to fixation that we could see because of this other testing, as well as some suspicion of progression here in the ganglion cell structural test. And when is it, regarding the literature, the situation in which we should order a 10-2 to further explore the macula in our patients? So there's evidence if we see that any of the 4 central points in the 24-2 have a deep defect. Also, when you see a very deep focal or notching in the neuroretinal rim, and also in patients in which we have found a pathological change in a central 24-2C point. Okay, and now finally, I'm going to talk about little aspects of OCT angiography. In progression, OCT angiography alone has not been proved very useful because of its high variability. However, it's been shown to have some utility in risk stratification in a way that those patients that have less peripapillary and macular vascular density at baseline, those patients have greater change, greater loss in retinal nerve fiber layer. And in terms of the macula, those patients that have microvascular dropouts at the choroid level, and I'll show you that in a minute, those have shown more rapid thinning and especially greater central visual field damage in the visual field testing. So we see here a 64-year female with slightly myopia that has a normal tension glaucoma. Here, there's this inferior notching in the rim, peripapillary atrophy. In the OCTA, we can see this characteristic area without vascularization. The microvascularization is lost, is all black here. And if we go to deeper slabs, trying to see the choroid, we can see how in this same area in which this inferior notching was, we can see this loss of choroid. This is what is called microvascular dropout. And in this particular patient, we can see a significant, relatively fast progression, and especially involving these paracentral defects. So this idea of looking at the choroid in these cases, especially in normal tension glaucoma, in which those defects are more frequent, will be useful to personalize more aggressive treatment in these patients. So in conclusion, assessing macular progression in glaucoma is useful, especially evaluating structural macular damage needs to have aging into account and consider those minus 0.32 microns per year. It's useful in advanced glaucoma, and it complements early damage as well as give us more information in myopic patients. Regarding function, sometimes 24-2 underestimates central points, so we need to use more and more 10-2. However, it's still not used if it needs to be used every time in all our patients. But there's some evidence showing that it will give more information, especially in paracentral defects or focal damage, and then 24-2C may have some utility in screening in selected cases. And OCT angiography, although by itself is not useful to detect progression, it may be or it may have value as a biomarker. And those patients with choroidal microvascular dropouts may have more susceptibility to have macular central damage. And this is all. Thank you very much for your attention, and I'm all ready for your questions.
Thank you, Marta. Now we have time for questions and answers that you can ask to each of the panelists.